Good morning, everybody. At the outset, my apologies for not being able to come there physically, as I had already agreed to give a talk at the same time in another conference. I would like to congratulate the organizers purely for having a topic called telehealth in India. I personally like the word telehealth rather than telemedicine, past, present, and the road ahead. It is essential that ultra specialists like you, people who are highly focused on speech pathology and audiology, understand the big picture and look at telehealth in the broader perspective than just look at audiology alone. And I really appreciate the organizers for using this topic. On the right-hand side of the bottom panel, you see the world's first VSAT-enabled village hospital, which was formally inaugurated by Bill Clinton, the then president of the US, when he visited Hyderabad on March 24th, 2000. This was indeed the formal recognition of telehealth in India. In the last 26 years, we have made enormous progress. Retrospectively, looking back, it looks so silly that I got so excited in holding multi-point video conferencing conferences with the 5 different continents of the world. But believe me, in 2001, 25 years ago, this was something unheard of. I remember telling the audience, good morning, good afternoon, good evening, and good night, because this was the time zone in the various continents. Bill Gates was one of the speakers. Subsequently, of course, ISRO has formally acknowledged publicly that ISRO got into telemedicine in a big way. Today, ISRO has 400 VSATs spread over the remotest parts of India purely because of the enthusiasm and interest shown by the Apollo Telemedicine Foundation 25 years ago. Now, let's see what exactly happened. Those days, telemedicine was literally unheard of even in most other countries. We used to have visitors, the president of Nigeria, the prime minister of Mauritius, ministers from Uganda, a delegation from Netherlands, and so on. We had the audacity, if I can call it now, to hold an international conference in Madras, where the then chief minister was the chief guest. So subsequently, tremendous amounts of progress has been made. I would like to spend a minute on what exactly I mean by the process of telemedicine. Today, if I were to make this slide again today, I would change the word patient to beneficiary, and I would change the word doctor to healthcare provider. Most of you are not medical doctors, may not have an MBBS degree, but you people are playing a very major role in the field of speech pathology and audiology. Now, essentially, telemedicine consists of the use of technology, the use of medical records, professional negligence, etc. Standards need to be considered. On the left-hand side, you see the important components of telehealth, namely hardware, software, connectivity, acquisition of images, storage of these images, the ability to review these images from a distance, which involves retrieval, display, and so on. In the last few years, thanks to a strand of RNA, the COVID, which acted, as I always say, a global CTO, Chief Transformation Officer, telemedicine or telehealth has today become an integral part of the healthcare delivery system, not only in the private sector, but most gratifying in the government sector. The central government and most state governments in the country today have a nodal officer exclusively for telemedicine. In 2026, you cannot deploy telehealth unless you have had formal training, your own the vast advantages which are taking place here. Customization, of course, for any project to succeed, it must be cost effective. And today we have regulations. It must be self-sustaining and, most important, future ready. I'm going to spend a minute or two on the clinical use of telemedicine. We need to understand it doesn't matter whether it is a neurosurgical examination or an audiology examination. or a speech pathology examination, the standard of care should be the same as used in a face-to-face examination. Please remember that technology is a means to achieve an end and not an end by itself. My favorite phrase is, a fool with a tool is still a fool. We should not go in search of solutions because we have already have a technology on our behalf. It is the individual behind the machine that counts ultimately. Professional judgment alone matters. It doesn't matter whether it is general medicine, general surgery, ENT, or whatever it is. On March 24, 2020, 3 weeks after the corona was identified as a pandemic by the World Health Organization, the government of India formally announced guidelines for telemedicine. Now, what are these guidelines? Essentially, they consist of 7 elements. The context in which technology enabled remote healthcare is done. Now, here, unlike a face-to-face consultation, the beneficiary at the other end may not be familiar with you, and I strongly suggest, even for paramedics, even for experts like you need to identify yourself. If you have a number with the Rehabilitation Council of India, I think it's essential that this be displayed. Similarly, you may not know the patient, you may not have seen the patient, and therefore identification of both the registered medical practitioner or whoever is giving the expert advice and the patient is essential. Mode of communication. In 2026, video conferencing should be an integral part of telemedicine consultation, though theoretically even a telephonic consultation would come under remote health care. Consent, type of consultation, patient evaluation, patient management. The government has laid down very clear guidelines, and generally it's an implied consent. So when somebody calls you and asks you for your opinion and advice, it is an implied consent. However, there are many other explicit consents which are necessary, but this is more in the case of surgical practice, obstetric practice, and so on. So you need not bother about it. The single most important thing is trust, trust, trust. I belong to the BC era, trained in the 20th century, 52 years ago. The doctor and the patient in the late 60s, the trust was absolute. Unfortunately, today, trust is slowly becoming a rare commodity. Now, what is the technology used? I'm not going into the details. When I started telemedicine 27 years ago, we had 64 128 kbps. Today, the average is 5 to 10 megabytes per second, and we even have bandwidth of 100, 500, and even 1 gigabyte per second. So video today is totally different from what it was several years ago. Audio, now here, I am not an expert. As a layperson, I presume that any audiology, speech pathology, evaluation, you require excellent audio. Probably the standard of audio required by you will be even higher than that used by us in remote teleconsultation. Of course, we can do teleauscultation where we hear RALs, Ronchi, etc. Echocardiograms, I'll show you an echocardiogram. The sound of the arterial blood, the venous blood going through the mitral valve, through the tricuspid valve, etc. A very high level of audiometry. Audio is required. Again, today it is possible to do an audiometry in great detail from one continent to another continent. Then, of course, we have text-based, chat-based telemedicine. Today, chat bots are available even in India where you interact with the humanoid. There are different types of teleconsultation called synchronous and asynchronous. In asynchronous, the reports are given. You evaluate the reports. Subsequently, either talk with the patient or just give your opinion about the reports to the remote medical practitioner. Most of us would prefer to do a synchronous teleconsultation, meaning I would like to directly interact with the patient and the patient's healthcare providers. Since my topic is the past, present, and future, I think it's not out of place to show how from Madras we persuaded the Southern Command, who put telemedicine as early as June 2002. And ISRO, of course, as I told you, were mainly motivated with the primary work which we did at Arabanda for the first 2 to 3 years. Now, this is again a classical example of how it is individuals who drive something. Of course, I'm talking of 20, 25 years ago. Major General Jamwal, I literally persuaded him, and then he put up with my assistants 8 telemedicine centers in the Andhra, Tamil Nadu area. He then became Adjutant General and was promoted as a Lieutenant General. And we set up telemedicine in the Central Command, in the Northern Command, etc. But this was in 2003, 2004. But after he retired, unfortunately, most of them died a natural death. Similarly, as early as 2003, to the best of my knowledge, this was the first course in South Asia. I started a course with Anna University. We ran 6, about 20 to 25 people attended a batch. Any graduate. I remember there were even 1 or 2 people with MSc in speech pathology. But unfortunately, we were able to give appointments to jobs to them only for 2 people out of 6 courses, and hence we had to stop the course. In 2026, there are at least 20 to 30 courses now being organized, and the most recent one is with the Tamil Nadu MGR Medical University, which is now offering a certificate course. We are now in discussions with the IITs and other major universities, and hopefully within a year or 2, we will be having a master's degree course on digital health. So this is the progress made over a quarter of a century. Again, I would like to emphasize that courses in telehealth technology were so rare. We had people from all over the world literally coming, doing internship with us. Harvard Business School, Yale Institute of Management. We signed an MOU with Georgia State University, with Wharton College, etc., long, long ago. Now, these are just to show you that technology is not that important. It is the individual who's passionate about the deployment of technology. I have personally given maybe about 4,000, 5,000 teleconsultations. And here you can see it is very simple. We don't require, on the lower right-hand side, you can see, as a neurosurgeon, I'm just looking for palatal movements for 9th and 10th nerve paresis, etc. With a simple, where patient is extending the neck a little, a torch is being shown, that is all. Today, we have many more devices, and it will be able, most of you can do a reasonably good clinical examination as you would do in a face-to-face consultation. Since the time is limited, I'm going to give you a bird's eye view, an overview, as it were, to tell you that there's almost nothing which telemedicine cannot deploy. Teleophthalmology, India is one of the leading centers in the whole world, and Aravind Eye Hospital, Shankar Nethralaya, the 2 of them alone do about 5,000 to 6,000 teleconsultations every single day. And this is for several years. And again, thanks to the teleophthalmology, we were able to make mobile medical units. We put up VSATs on the roof of these customized mobile medical units, which go to small villages, and an expert in the city, in the big cities, are able to look into the fundus of the patient. And today, this is a standard method. On the right-hand side here, lower, you can see more than 1 million fundus examinations were done with a totally indigenous Forest Health. They manufactured a totally indigenous fundoscope tool, which today is being exported to at least 20 to 30 different countries at about 20% of the international cost. Now, again, Apollo hospitals, we are doing teleophthalmology in public-private partnerships. 2.7 million spectacles have been dispensed to beneficiaries. The refractive error has been documented with an with not even an optometrist. Many of these people are school dropouts, 10th standard, 12th standard. Those 4 weeks, 6 weeks, they've been trained what to do. We have an optometrist, a refractionist, who escalates, if required, to an MS in ophthalmology, and this is what is done as a routine. 3.5 million beneficiaries have been screened from 30 ophthalmologists in Chennai, 30 ophthalmologists in Hyderabad and other places. At the peak of the COVID, intensive care was extremely difficult, and within 10 days, we actually put up 7 intensive care units for the Government of India public sector undertakings, National Thermal Power Corporation, and so on and so forth. We have a command center in Hyderabad, where today the command center is connected to, I think, almost about 85 or 90 ICU units. This was a paper which I published several years ago on 61 neurological patients in ordinary intensive care, meaning it was not a neuro-intensive care, but my intensive care specialist from my Hyderabad handheld an MD general medicine or an MD anesthesia and gave them state-of-the-art neuro-intensive care. Again, we are extremely delighted that these papers have been quoted in the world literature very well. We set up the world's first 24/7 tele-emergency services. Can you imagine 15 years ago, we were able to get a cardiologist, a neurologist, a general surgeon, you name it, the specialist within 30 to 45 minutes, 24 hours in a day with a patient in the Himalayas at a height of 15,000 feet when the temperature was minus 25 degrees centigrade. We have diagnosed at least 8 cases of myocardial infarction in evolution. As the heart attack was evolving, my specialists in Greens Road, Madras, were able to diagnose it and initiate thrombolysis. Our well-trained nurses in the Himalayas who carried out instructions given by the cardiologist here. We have been able to considerably reduce the number of helicopter evacuations, which has now become a rarity. And there are so many, all these are available in the literature, in published literature. Again, as I told you, MMUs, mobile medical units, these are available. Apollo Hospital Group alone has about 100 mobile medical units, mainly used in northeastern India, in Meghalaya, Jharkhand, Chhattisgarh, and other remote areas where it is now being used on a day-to-day basis. So here you can see details, NCD screening, cancer screening, and so on. On the right-hand side, you see the interior of a mobile medical unit and the doctor in one of the big cities evaluating the patient. These mobile medical units go to various villages on specific days, Monday this village, Tuesday the other village, and so on. We keep abreast of technology. We have 5G enabled ambulances now. I think there are almost 30 to 40 of them. And pre-hospital management is now a routine among the big tertiary quaternary care hospitals in India. All of us have seen Netflix, seen movies where whatever is available in Western countries today is available in India at a fraction of the cost. Onboard cameras, camera-based headgear, body cams, every one of this. Our ambulance drivers are do polytasking, all of them are trained, and believe me, pre-hospital management starts, and particularly with EMR, medical records, all being digitally stored. By the time a patient comes to the ER, we know his blood group, if he has been a patient earlier on, not only in our hospital, but in some other hospital. We know what are his allergies. We know quite a bit about him. The theater is kept ready because the decision to operate has already been made while the patient is inside the ambulance. So this is the state of healthcare in India. 4 years ago, I started a conference, a whole day conference on the use of drones. Many were skeptical about it, but in the last 4 years, it is amazing how drones are used. The Sindoor conflict, every citizen of the country today knows how drones were used in warfare, but not many may know that drones are also being used by many, many hospitals. We did a pilot project supported by the World Economic Forum, and today the World Economic Forum has accepted our the detailed SOP, which we have guidelines which we have made. And today drones are used in Meghalaya, in Uttarakhand, and several other states, not only to drop medicines, but to collect samples as well from very, very remote areas. Social benefits of telehealth. and I would strongly urge this organization. I think you are a great All India Institute of Speech and Hearing. I remember reading about it, knowing about it, even when I was in medical college half a century ago. I think you have the capability of doing fantastic things, social benefits. Today, with multi-point video conferencing, I did this for 5 years. Unfortunately, I was not able to raise funds at the end of the day unless there is some compensation, particularly for the younger doctors, younger people. It's difficult to spend hours and hours purely on a voluntary basis. So I did this with the MSSR of MS Swaminathan Research Foundation. 20 villages were connected, and every alternate Saturday, we gave almost 100 talks over a period of 5 years. More than 30,000 villagers benefited from it. Management of diabetes, hypertension, recognizing the dangerous headache, speech problems, and so on and so forth. This could be a great PhD thesis for somebody. Unfortunately, I was not able to get anybody to help. And after the COVID came, we were unable to continue. These are further photographs to show about the cooperation with the MS Swaminathan Research Foundation. And I really think that we made a difference. Promoting health literacy, I think, is much more important than giving antibiotics. And this was a statement made by the Chief Knowledge Officer of NHS in England. And today, promoting health literacy is not at all difficult. All we require is motivated people, both for the recipients as well as for the lecturers. In Hyderabad, we have probably one of the largest medical response centers in India. 250 computers, 250 desks. At any given time, at least there are 150 people. This is available round the clock, and these are all paramedics trained. I think there are a few MSc speech hearing all people also. We have MSc nurses, MSc physiotherapists, occupational therapists who do moonlighting, meaning they work here after the regular work is over, and we are able to escalate it to an MBBS, to an MD, to a DM, to an MCH, and so on and so forth, depending on what is required. This is operational. I have formally stepped down from the Apollo hospitals a year and a half ago. When I left, we were doing 20,000 teleconsultations every single working day. And here you can see most of our customers, 90% of our customers is the government, public-private partnership. We took over 195 urban primary health centers, and we totally changed that completely, made it digitized. So 195 digitally enabled primary health centers in the erstwhile Andhra Pradesh. Similarly, teleophthalmology, 115 centers we took over, and on any given day, we have at least 8 to 10 people coming per center, which means 1,000 people coming every single day. In the last 4 years, I think we have evaluated 2.1 million, 700,000 fundus examinations, and so on. Similarly, we have similar projects in Jharkhand, Chhattisgarh, and so on. I will now come to the final part of my talk. I was asked to talk on present, past, and the future. The future is always ahead of schedule. When I say the future, I'm not talking of 2030, 2035. Most of these things which I'm going to present to you now, I'm very, very optimistic and confident they're going to occur in my lifetime in the next 1, 2, 3 years. These slides are self-explanatory. Just look at the smart fork, smart chopstick, smart cutlery, which will tell you exactly what is happening in the food which you are taking. Again, playing games. I remember how angry and irritated I used to get when my grandchildren were playing video games several years ago. Today, the FDA has formally authorized games, and some of these games are available only on prescription. Video games are now prescribed by neurologists in the management of autism. I think this overlaps with your specialty in attention deficit syndrome and many other conditions where speech pathology is also involved, including speech therapy. A lot of these things are now available. So these slides are really self-explanatory. Screening oral pre-cancer. Indirectly, I'm sure all of you are much more involved with phonation, with the mouth. You need to exclude local pathology in the mouth. before trying all your other treatment. I mean, there's no point in teaching somebody speech therapy when he has got a big growth inside the mouth, which is obstructing the normal phonation process. Today, it is extremely simple to organize this, to send this. We have done it very successfully in Meghalaya for the last 2 years, and we have been able to pick up in the pre-cancerous stage. Today, with proper lighting, proper camera, etc., you can can take a smear, can take a biopsy from 7 o'clock position, 8 o'clock position, etc. And very soon, within hours, we can examine it under the microscope and say whether it is pre-malignant, malignant, and send the patient appropriately for treatment. It's fascinating to see that digital pathology now is a reality in India. Postgraduate Institute in Medical Education and Research in Chandigarh, the government of India has established a center of excellence for telepathology, which then was connected to 28 medical colleges. I think it is connected to many, many more now. So today, of course, in 2026, AI is also being used. Teleradiology. This slide is borrowed from a good friend of mine, Arjun Kalyanpur in Bangalore. He set up this more than 15 years ago, and today it is one of the biggest teleradiology centers in the world. You can see here they are connected to 25 countries. Can you imagine that? 25 countries they are connected, including the US, many universities in the US, because it's very difficult to get a specialist radiologist to report on a CT or an MRI at 11 o'clock at night, US time. So Indian time, within 15 minutes, the report is given and sent. A detailed annotated report is given. This is where India is. India no longer follows the West. India no longer piggybacks. We pole vault. We are far ahead in most situations. Can you imagine carrying a backpack which weighs 3.5 kilograms, which has got a truly portable X-ray machine? It is just like a laptop, actually smaller than a laptop. We have been doing this TB screening for more than 1.5 years now. And again, though we are using Fuji films, we are using a Japanese. Very recently, an indigenous product made in Pune has been approved by the World Health Organization. And I foresee that in the next few years, people, ASHA, the activated social health activists, the nurses, nursing assistants, and so on, will be carrying this backpack to the remotest parts of India, taking an X-ray. The X-ray will be sent through Bluetooth, internet, etc., etc. And within 45 minutes, it is possible for a radiologist to give the report immediately. We have been doing this as a pilot project. It's just a question of time before we escalate this and becomes part of it. This again to show how amazing India is. Again, this slide is from Dr. Saroj Mishra, a good friend of mine, who as early as 12 years ago identified that the Kumbh Mela could be a great project to do telemedicine, telehealth. Today, it's absolutely fantastic the way they look after millions and millions of people. They've diagnosed cholera before it could spread. The microscope, the smear was looked from SGPGI Lucknow. Cholera was identified. Precautionary measures was taken. The public doesn't know this. We always complain. We always say we don't have that. We don't have this. But do you know the number of public health serious problems which are averted by the use of telemedicine? Telegenomics. I wrote this article a few years ago, and at that time it was theoretical. Today it is practical. For 20,000 rupees, which still is a large amount of money, what used to cost $20,000, we can now do for 15,000 to 20,000 rupees. There are at least 20 centers in India which can do 99.5% of your genome. And I do know there are a lot of genetic based conditions which come under your area of expertise also. So I think in the next few years, speech pathologists and audiologists will need to know something of telegenomics so that you can even identify this. Ayurveda, Unana, Siddhi, all these things, AIISH, everything today have formed their own telemedicine guidelines. The future is always ahead of schedule. 7 years ago, I brought out a special edition of Neurology India, which is the world's fifth largest journal in neurosciences. It was an entire issue devoted to extraterrestrial neurosciences. I got 12 articles written by the authorities in the field and put together. Today, 7 years later, ISRO is doing amazing work in the field of healthcare, and the next couple of years we will have several byproducts entirely because of collaboration with ISRO. Astronauts' blood clot gets treated by a doctor on Earth. 10 days ago, it was announced in the media. Of course, they have downplayed it, that the International Space Station, there are 4 astronauts. There are actually 11 now. 4 astronauts were brought back to Earth about 2 months ahead of schedule because one of them developed a major medical problem. It is top secret. We don't know what exactly is the problem. We don't know which one of the 4, but this is history's first recorded episode of medical evacuation 230 kilometers, 230 miles, above the Earth. I could go on and on. I didn't keep a look at the watch. I don't know how long I've taken, but I would like to conclude by saying it is fascinating to see that telepractice in audiology, the number of publications, the number of presentations, number of lectures was amazing. And thanks to this invitation to give a talk, I was able to do a little more homework on this. And it was fascinating to see that telepractice in audiology is a distinct area, a distinct discipline. And the fact that the Institute of Speech and Hearing in Mysore is getting involved in this, you have a separate division, department, and all that is absolutely fascinating. The number of courses in telespeech therapy, and may I make use of this opportunity? If you would like to start a course, please do contact me. I am a past president. I'm a founder of the Telemedicine Society of India. We have almost 1,800 members now. They would be very happy to collaborate with you and help you to start a course on telespeech therapy. I think the time has come. Now, telepractice in SLP and audiology, I shouldn't be telling you about all this, just more to remind myself that telepractice can exist in pediatric care, in adult disorders, in brain injury, traumatic brain injury. I see hundreds of traumatic brain injury, certain types of dementia, etc. Cochlear implant. Cochlear implant is now available in at least 150 different places in India. And I do know personally, some of my very close friends of mine, little children, have undergone cochlear implant. I know the difficulties they had in getting the hearing done, evaluation done from a distance. I think there is a tremendous future just to follow up cochlear implants. Of course, there are implementation challenges, but the more the problems, the more the fun it is in overcoming them. Limited broadband access. I am very optimistic that in the next 3 to 4 years, this is not going to be a stumbling block. We will have enough broadband access ever. I was really surprised to see this when I was preparing for this lecture. I had no idea that there is an interpreter-enabled telemedicine for the deaf. On TV, of course, I've seen this, but I had no idea that conventional telemedicine can take place with sign care telemedicine for the deaf. I think this is absolutely amazing. I would like to conclude. I had the opportunity to interact. Some of you may know her, Dr. Vidya Ramkumar. I think she's doing fantastic work. As early as 2011, we encouraged her. She presented a paper in the TSI conference, and since then, she has been a very active member for the last 15 years. I was one of the people who evaluated her PhD defense in 2016, and it's extremely gratifying that I think she already has 3 people who have got a PhD in telemedicine and speech pathology. And I wish many, many people do this. And I'm not promoting an individual, but just to tell that this is a great example of community, of what audiologists, a passionate audiologist can do, can literally make an impression in hundreds and hundreds of people. So, ladies and gentlemen, I could go on and on, but what is my take-home message? My take-home message is, it is 26 years since we embarked on telehealth. Our universe has changed. India should no longer follow high standards. We must set them. We no longer should be striving to achieve world class. That was in my generation. My generation, we wanted to achieve world class. Your generation, you should make the rest of the world achieve India class. It is definitely possible. Nothing can stop an idea whose time has come. Creating awareness and convincing society that geography has become history, distance has become meaningless. I always repeat again and again, we do not leapfrog. After all, how much can a frog leap? Today, January 2020, February 2026, we should pole vault. So let this be your motive. Do not think of achieving world class. Make the world achieve All India Institute of Speech and Hearing Mysore class. Thank you once again for giving me this opportunity to talk to you.